Hello and welcome to lecture number 15 in the series on drugs and human behavior. Today we're going to be talking about psychopharmacology across the lifespan. Specifically, in this lecture, we're going to talk about child and adolescent psychopharmacology. The following lecture in this series will be on geriatric psychopharmacology. But today we're going to talk about child and adolescent psychopharmacology. I think it's really important to understand, before we get into this topic very deeply, that prescribing medications for children and adolescents is a completely different thing from prescribing drugs for adults. Oftentimes, physicians and other practitioners have taken the approach that children are just smaller adults, and that's not the case. They have very different metabolic systems, they're obviously growing, a completely different hormonal situation. So it's really important to keep that in mind. And many of the drugs that we'll talk about are oftentimes written off-label for adolescents, and so it's kind of a wild west out there. So you have to be very cautious and really try to dig into this a little bit deeper. We're going to present some of the issues, talk a little bit about some of the research, but it's never an easy question about providing a psychotropic medication for children unless it's absolutely necessary. So we'll talk about today some child and adolescent psychiatric illnesses, talk about pregnancy and psychotropic drugs and issues there, talk about preschool psychopharmacology, and then get into really the sort of typical things that come up in children and adolescents: autism, attention deficit hyperactivity disorder, depression, anxiety disorders. Talk a little bit about omega-3 fatty acids, and then finally finish up with medications for treating psychotic disorders. So about 13 to 20% of children between the ages of 3 and 17 years experience some mental disorder in any given year. Half of all lifetime adult psychiatric illnesses start prior to the age of 14. These include anxiety disorders, depression, attention deficit hyperactivity disorder, and schizophrenia, bipolar disorder, eating disorders, autism spectrum disorders, etc. So this is a pretty significant problem with mental illness in children and adolescents. In particular, anxiety, depression, and ADHD seem to have their sort of greatest toll in childhood and adolescence. Schizophrenia, oftentimes age of onset is late teens, early 20s. We talked already about bipolar disorder, and oftentimes the first symptoms are at around age 15. Eating disorders are certainly oftentimes arise around 13 or 14. And then autism spectrum disorders, of course, start during early childhood. I want to talk a little bit about pregnancy and psychotropic drugs. This is a tough issue to struggle with because we don't want to leave women untreated, but we also want to limit the teratogenicity of these drugs. I want to make it very clear, no psychotropic drug is FDA approved for use during pregnancy. So any use of these drugs is probably something to be taken very seriously. No decision regarding psychiatric treatment is risk-free, and no decision is perfect. Again, I think it's entirely up to women and their doctors to make this decision together. But more than 500,000 women each year have a psychiatric illness that either predates or emerges during pregnancy. Pregnancy is a pretty difficult thing oftentimes. The hormonal changes oftentimes can really be problematic for some women, and certainly depression can emerge during that time, and anxiety about being a mother. Certainly perfectly understandable. So we want to make sure that we are responsive to these needs and make sure that treatment is available. We know that psychoactive medications cross the blood-brain barrier, so as a rule the fetus will have the same blood level of drug as does the mother, because the placental barrier is far less effective than the blood-brain barrier. Risks of using psychoactive medication include potential teratogenic damage, so some sort of structural damage to the fetus if mothers continue their medications during pregnancy. There is problems with postnatal behavioral abnormalities from medication administered during pregnancy. We'll talk about antipsychotics being administered in the third trimester oftentimes result in behavioral abnormalities in infants. Some perinatal syndromes or neonatal toxicity from breastfeeding from medications continued after pregnancy. Many of these drugs will express themselves in breast milk. But there are also risks from untreated mental illness during pregnancy. Poor compliance with prenatal care, inadequate nutrition. We know depression, certainly oftentimes people don't eat or don't eat well or don't eat right. Possible exposure to undesired drugs, medication, or herbs that may be worse than the psychotropic medication. Sometimes we'll self-medicate with alcohol or other drugs. Again, increased caffeine, alcohol, and tobacco use, all of which are problematic during pregnancy. We can have deficits in infant-mother bonding and disruptions to the family environment, all because of inadequate treatment from mental illness. So here's a quick summary of the potential impact of untreated mental health illness on pregnancy outcomes. So for anxiety disorders, untreated can end up with long labor, fetal distress, preterm labor, or spontaneous abortion even. In terms of the neonatal complications, reduced developmental scores, slowed mental development. One option is fluoxetine as a drug, but probably some psychological therapy is, I would say, a better choice. For depression and dysthymia, it can result in low birth weight, reduced fetal growth, and postnatal complications, reduced hippocampal volume in mother and possibly infant. Those increased stress hormone levels can result in reduced bonding, small size, and low weight. SSRIs, there are a few options. Certainly psychotherapy, maybe omega-3 fatty acids, and electroconvulsive therapy has been increasingly used to treat pregnant women. Bipolar disorder, similar risks all around. There are some options available we'll talk about. And then with schizophrenia, untreated, increased rate of postnatal death, preterm low weight, which can potentially be treated with antipsychotics. One of the important things to understand about treating depression in women is some sort of adequate treatment is important. So if you look at the people who relapse or don't relapse, they're less likely to relapse if they continue their medication during pregnancy. So finding the right medication is probably important. So women with severe pregnancy during risk are at high risk for relapse. Depression during pregnancy results in increased risks of postpartum depression. And women who discontinue medication do relapse more frequently. So this is an important consideration. So let's jump right into what are the problems with SSRI-Type antidepressants, since this is the most common. The FDA has warned that Paxil use during the first trimester can result in increased risks of congenital malformations, mostly cardiac defects. The American Council of Gynecologists, or Obstetrician Gynecology, advises against the use of paroxetine, sertraline, and escitalopram during pregnancy because of an increased risk of the incidence of congenital malformations, although it's very small. But fluoxetine or Prozac had the lowest risk, so that's probably the best choice. A follow-up paper did not support the association between SSRI use and major congenital malformations, but I think safer than sorry. I would certainly avoid Paxil during the first trimester. So probably fluoxetine is the best choice, or perhaps trying omega-3 fatty acids, or if it's severe enough depression, some ECT. So the use of mood stabilizers during pregnancy, untreated maternal mood disorders are serious risk factors, including impulsivity and impaired judgments of the pregnant mother, poor self-care, drug and alcohol abuse, manic episodes, interpersonal life disruptions. All of these have potential harmful effects on the fetus as well as the mother. There is some teratogenicity of mood-stabilizing medications. Lithium seems to be a modest teratogen. There is some risk of cardiac malformations. Valproic acid is the worst, so let's avoid that. Carbamazepine is slightly teratogenic. Risk of adverse fetal outcomes is increased by about 3%. Lamotrigine is not considered a major teratogen. Slight risk for cleft lip or palate, which is treatable with surgery. Topamax is associated with increase in major congenital malformations, including oral clefts and penile malformations. So that's probably another one to be avoided. So lamotrigine is probably the go-to drug. Also potentially lithium if it's severe enough. Typical antipsychotics have long been used in early pregnancy to treat nausea and vomiting, so they're not associated with any major teratogenic consequences. These drugs should not be discontinued in treatment of pregnant women because risks of treatment discontinuation outweigh any risks of medical continuation. Clozapine and olanzapine are associated with high birth weight, so there is a possible risk of diabetes, so these probably aren't the best choice for pregnant women. Risperidone or Risperdal is used in the third trimester, can be associated with some infant jitteriness, irritability, feeding problems, and somnolence. Should be used during pregnancy only if the benefits outweigh the potential risks. So probably best to avoid that certainly in the third trimester. So while the risks associated with use of some of these drugs during pregnancy may be high, the risks from not treating are also high. So it's a tough decision to try to make. The best thing to do is to be as informed as possible. Try to make an informed decision with your doctor and do the best that you can. But again, there are certainly some drugs to be avoided and some drugs that certainly are just fine. So this moves us into talking about preschool psychopharmacology. There is scant research or practice guidelines prior to 2007. In fact, there's still not a great deal of research. It's very hard to do research in this age range. Preschool children with severe mental health problems present a dilemma when they don't respond to non-medication interventions. In this population, psychopharmacology responses are probably the last choice. So drugs are probably going to be our last resort in this area. So trying other forms of behavioral intervention is certainly the first thing to try to do. So the focus in young children with moderate to severe symptoms or impairments. Some psychopharmacological interventions are not indicated for preschoolers with mild or single content symptoms or impairments. So these are only for severe cases in preschool children. So those with severe symptoms or impairments, they're not able to function, they're not able to go to school. This has to be a severe case. So again, these are drugs of these are the sort of treatment of last resort. So for some cases, there are appropriate uses of these drugs. So for attention deficit hyperactivity disorder, an average dose of about 14 milligrams a day in immediate release product produce significant reductions in ADHD symptoms, though that's not as efficacious as for school-age children. The protocols are, if it's effective, no more than 6 months, and then reassess and see if that hasn't spurred some sort of development that can be continued without further use of these medications. For severe disruptive behaviors, the use of atypical antipsychotic drugs without any accompanying psychotherapy, this is often done as what we call sort of a chemical restraint. They're just simply given to get children, these kind of children, to just behave or not be a problem. And this is certainly not something that would not be endorsed, and I would never endorse this kind of use of these kinds of drugs. These drugs are for severely impaired children only, not for caretaker convenience. For depression, psychotherapy, not medication. No antidepressants in this age group. For bipolar disorder, there's no clear consensus that bipolar disorder occurs in preschoolers, so I would be against any treatment there. And then for autism spectrum disorders, there are 2 drugs that show some use for treating this disorder. So risperidone showed 63% positive response rate for behaviors associated with autism, and it's been approved by the FDA for ages 5 and over for behaviors associated with autism. Aripiprazole is FDA approved for irritability associated with autism for ages 6 to 17. And so that's a possible way to treat the kind of irritability and difficulty with autistic kids. In terms of the clinical guidelines for psychotropic medications in children and adolescents, so before initiating psychotherapy, there should be a complete psychiatric evaluation, including physical evaluation, all of that. When appropriate, should include a history and medication evaluation and treatment. Should communicate with other professionals to obtain history and set the stage for monitoring of any use of these medications. Before prescribing, develop psychosocial and medication plans. This isn't a case where kids at this age should just be, their parents handed a prescription and sent on their way. There needs to be a plan. It needs to include therapy. It needs to include some psychosocial help. It's There's also, we need to develop short and long-term plans for our outcome monitoring. How are we going to know if this is working? How are we going to know if it's going to continue? We need to know that before we dive into these things. If there's no monitoring involved, proceed with caution. I would actually argue proceed not at all if there's going to be no monitoring. Everyone needs to be educated about the treatment plan. You need to document the assent of the child and consent of parents. Focus on risks and benefits of medications and alternatives. So a thorough evaluation, trying to decide what's the best course by looking at risks and benefits. Best thing to do is implement a medication trial. 30 days. Come back in 30 days and we'll see where we are. Come back 30 days after that. Reassess treatment plan if there's no response to the initial medication. Develop a specific plan if there is a medication for discontinuation trial. So, figuring out how we're going to go forward, not just throwing a prescription out and hoping for the best, is certainly not an appropriate way to go about that. So, we'll move now into talking about sort of longer-term treatment of children and adolescents beyond preschool. We know that there is an increase in the diagnosis of autism, primarily due to alterations in how we diagnose autism and education about diagnosing autism. Psychotropic drugs have been shown to reduce aggression and self-injurious behaviors, anxiety, those repetitive stereotype behaviors, and other maladaptive behaviors in autism spectrum disorder children. Medication may be particularly useful to reduce physical aggression and self-injurious behaviors in adolescents. As they get bigger and they get stronger, this can become more dangerous for caregivers and for the child themselves. So this is really only in cases where this kind of aggression is problematic. Certainly not all autism spectrum disorder kids are going to need this kind of medication, but those that might, the atypical antipsychotic drugs seem to be the most clinically effective. So that's what we're going to turn next, talk about atypical antipsychotic drugs. They can reduce the irritability associated with autism. They do have serious side effects, much like we talked about already, weight gain, glucose intolerant, hyperlipidemia. So monitoring is going to be very necessary for these patients. Some changes are resistant to treatment, even with stimulants. Aripiprazole appears to have fewer metabolic and sedating side effects, but are unknown if it improves the core symptoms of autism. Risperidone has been formally approved by the FDA for treating irritability in autistic children and adolescents. Also improve mood disorders and reduce disruptive behaviors. Let's take a look at that. So here are it's a mean irritability score. You can see pretty significant reductions in that score compared to placebo. So the only medication treatments for autism spectrum disorders are really those to treat those irritability and aggression. The core symptoms of autism certainly have no pharmacological treatments. So let's move on to talk about attention deficit hyperactivity disorder. This is certainly an area where most of the psychotropic drugs given to children and adolescents is in this area. Biologically, attention deficit hyperactivity disorder appears to follow from alterations in the dopaminergic activity in the prefrontal cortex. The prefrontal cortex is critical in regulating behavior, attention, and cognition. Lesions to the prefrontal cortex can produce distractibility, forgetfulness, impulsivity, poor planning, and locomotor hyperactivity. All are prominent in ADHD. This is why we think ADHD seems to be some disruption in prefrontal cortex functioning. The prefrontal cortex requires optimal levels of norepinephrine and dopamine. Essentially, those neurotransmitter levels are required for the prefrontal cortex to be able to take control, that is, to limit impulsiveness. One of the most important functions of the prefrontal cortex is to inhibit things that we don't need to pay attention to right now. And so that active inhibition process is important, and that occurs through norepinephrine and dopamine. And so this is why stimulants actually have this paradoxical effect of calming down ADHD children, because it allows that prefrontal cortex to take control again. So these stimulants tend to augment deficient dopaminergic and norepinephrine systems. These are one of the most broadly effective drug therapies. About 60 to 80% of children with ADHD show improved behavior and learning abilities when combined with education and mental health services. I think by now you've probably learned that I'm not a fan of just handing people pills and sending them on their way. Including education and mental health services is an important component of all of this, and particularly in this case. What's important from this data, though, is that the long-term learning outcomes are better for children who are appropriately treated. And I think that's something that's really important for us to consider. So the first of these drugs that is the most common is methylphenidate, which is Ritalin. It has a fairly rapid onset, but short duration of action. And short half-life is a problem in some children who sort of experience this end-of-dose rebound and dysfunctional behavior, so their medication wears off and they get this massive rebound. So that results in schools having to have medication available for the students to take. There are multiple dosage and delivery forms, so there are longer-acting forms that we'll talk about. The efficacy of this drug is due to increases in dopamine in the synaptic cleft by blocking presynaptic dopamine transporters. PET scan studies show peak levels in the brain about 60 minutes after oral administration. That's pretty quick. Concerta is a new formulation of this drug. It's a tablet that contains an osmotic pump that gradually releases methylphenidate over a 10-hour period, and then the shell just gets excreted. There are transdermal versions of ADHD, and caregivers report high satisfaction with the patch, improved behavior, and then less need to worry about missed doses. Adderall is another drug available for treatment. It is amphetamine and dextroamphetamine. It has a longer half-life, but certainly much greater abuse potential. Strattera is a norepinephrine reuptake inhibitor that's approved for treating ADHD in children and adults. It's more effective in treatment-naive patients than in patients previously treated with stimulants, so it suggests a trial of atomoxetine, which is Strattera, prior to the use of stimulants, so this might be the first thing to try rather than starting with stimulants. So there are, of course, side effects of stimulant medications, including insomnia, elevated blood pressure and heart rate, reduced appetite, possible growth suppression, potential for new worsening behavior and thoughts, new worsening bipolar illness, new worsening aggression and hostility problems, and in children and teenagers, the potential for new psychiatric symptoms, so want to watch out for that because potentially can cause some level of psychosis. So it's certainly something to monitor. Depression in children and adolescents is certainly can be a problem. There's a high prevalence of suicidal ideation and completed suicides among children and adolescents with depressive disorders. We certainly want to make sure that we are treating this disorder in these children to avoid this unfortunate occurrence. 62% of children with depression had experienced some sort of childhood adversity, so it's certainly something to explore. Adolescence is the period of highest risk for the onset of depression. Untreated childhood and adolescent depression is associated with later development of serious personality disorders in early adulthood. So treating depression in children and adolescents is an important thing to do. There are only 2 approved SSRIs for use in adolescents, fluoxetine and escitalopram. So we'll talk about these individually. Actually, we're just going to talk about escitalopram. Until recently, Prozac was the only drug approved in the U.S. for childhood depression. In 2009, the FDA approved Escitalopram or Lexapro for the treatment of adolescents aged 12 to 17. Significant reductions in, moderate reductions in child depression ratings compared to placebo. There are no head-to-head comparisons thus far between Lexapro and Prozac. One of the problems with treating children with antidepressants is they all have a black box warning on the potential for exacerbating suicide. In 2002, 264 children and adolescents died by suicide in the U.S. FDA report linked many of these deaths to SSRI treatment and recommended black box warnings to be required in 2005. Unfortunately, there's no clear evidence as to what was going on here. We do know that you get a reduction in SSRI use, also increases the rates of suicide. So as SSRI use in this population went down, rates of suicide went up. Most suicides occurred in the context of persistent depression and insufficient improvement. So it's not necessarily so that the drugs actually induce the suicidal behavior. One of the things to do is to add cognitive behavioral therapy. Again, not just prescribing, but adding cognitive behavioral therapy makes this a much safer proposition. So here's a summary and recommendation from the U.S. Preventative Services Task Force for broad screening of children and adolescents for depressive disorders. Assess for risk, provide some screening tests, including the patient health questionnaire for adolescents and the Beck Depression Inventory. They don't do as well in younger children, but certainly adolescents they can. In terms of treatment, fluoxetine has been found to be effective, but we need to include that with psychopharmacology. In terms of treating anxiety disorders, the best outcome with anxiety disorders is combining Zoloft with cognitive behavioral therapy. On their own, neither cognitive behavioral therapy or Zoloft or Sertraline are any different in terms of their outcome, so only the combination of those two seems to work. So the best thing for anxiety disorder is, again, cognitive behavioral therapy, possibly combined with Zoloft. One of the things we've talked about in a number of these talks is omega-3 fatty acids. And this is one of those things that there's such potential benefits for and no known side effects that I think it's worth exploring. So omega-3 fatty acid supplements that are high in eicosapentaenoic acid, if that's how you say that, EPA, was effective for children with ADHD, bipolar disorder, and other educational and behavioral problems. Omega Bright D supplement was evaluated in 20 children with bipolar disorder. Half experienced a rapid 30% reduction in symptoms with no side effects. So I think there is some potential to explore the use of these kinds of supplements like omega-3 fatty acids and DHA that maybe can help treat, certainly in younger kids, or prevent even these kinds of problems. So the final thing to talk about are medications for treating psychotic disorders, because it's so rare in children, prevents significant challenges when it appears. It occurs more often in adolescents with gray matter deficiencies in frontal parietal lobes before the onset of first episode symptoms. And 1 in 3 schizophrenia patients develop psychotic symptoms between ages 10 and 20. So the problem is there is not enough data in this area. If someone is showing psychotic symptoms, that has to be treated. The best treatments for those are going to have to be explored. So I can't make any recommendations for you. But it's certainly something that we need to consider and possibly certainly get some more information about. Well, thank you. That's our discussion of child and adolescent psychopharmacology. The next thing we'll have coming is geriatric psychopharmacology.